Chapter 22 of Katzung's board reviews. This chapter is all about sedative and hypnotic drugs. So, the sedative hypnotics belong to a chemically heterogeneous class of drugs, almost all of which produce dose-dependent CNS depressant effects that cause sedation with relief of anxiety or hypnosis, encourage sleep. So, they cause sedation or hypnosis. So, sedation is relief of anxiety and hypnosis is encouragement of sleep. So, the major subgroup is the benzodiazepines, but representatives of other subgroups including barbiturates and miscellaneous agents such as carbamates, alcohols and cyclic ethers are still in use. Atypical drugs with distinctive characteristics include the anxiolytic buciprone, several widely used hypnotics such as zolpidem, zaleplon and esopiclone, and melatonin agonists and orexin antagonists, novel drugs used in sleep disorders. So, coming to the classification of sedative hypnotics, so we have three major families of sedative hypnotics. They include benzodiazepines, barbiturates, and miscellaneous agents. So, moving on to benzodiazepines, we have short action, intermediate action, and long acting drugs. So, short action, an example is triazolam, intermediate action alprazolam, and long action flurazepam. Okay, benzodiazepine, PAM, flurazepam. Okay, so long action, long for far, flu spreads far away, so flurazepam. Okay, long acting benzodiazepine. The other ones are triazolam and alprazolam. Next, moving on to the barbiturates, we have ultra short, short and long action barbiturates. So, the examples for each are thiopental. So, sodium thiopental, people say it is used as a truth telling serum or something. So, ultra short action thiopental, they use it because it is ultra short in action. Then short action, you have secobarbital, okay, barbiturates barbital, and long action you have phenobarbital. Okay, so short action secobarbital, ultra short thiopental, and long action phenobarbital. And miscellaneous agents, you have buciprone anxiolytic, you have chloral hydrate, and you have these other widely used hypnotics such as zolpidem, zaleplon, and esopiclone, and you also have ramelteon. Okay, this is the basic classification of sedative hypnotics. So, talking about the pharmacokinetics and the absorption and distribution, so most sedative hypnotic drugs are lipid soluble and are absorbed well from the gastrointestinal tract with good distribution to the brain. So, drugs with the highest lipid solubility such as thiopental, ultra short acting barbiturate, enter the CNS rapidly and can be used as induction agents in anesthesia. The CNS effects of thiopental are terminated by rapid redistribution of the drug from the brain to other highly perfused tissues including skeletal muscle. Other drugs with a rapid onset of CNS action include esopiclone, zaleplon and zolpidem. So basically, if this is your brain, okay, the drug is redistributed to including your organs such as your skeletal muscles which are highly perfused. Okay, so that is why it is ultra short in its action. What is that? Thiopental. It is a ultra short acting barbiturate drug. So moving on to the metabolism and excretion. So sedative hypnotics are metabolized before elimination from the body mainly by hepatic enzymes. So metabolic rates and pathways vary among different drugs. Many benzodiazepines are converted initially to active metabolites with long half-lives. After several days of therapy with some drugs such as diazepam and flurazepam, accumulation of active metabolites can lead to excessive sedation. So lorazepam and oxazepam undergo extrahepatic conjugation and do not form active metabolites. So what are these exceptions that do not form active metabolites because they undergo extrahepatic conjugation? Lorazepam and oxazepam. With the exception of phenobarbital, a weak acid that is excreted partly unchanged in the urine, the barbiturates are extensively metabolized. So chloral hydrate is oxidized to trichloroethanol, an active metabolite. So rapid metabolism by the liver enzymes is responsible for the short duration of action of zolpidem. A biphasic release form of zolpidem extends its plasma half-life. So zaleplon undergoes even more rapid hepatic metabolism by aldehyde oxidase and cytochrome P450. So esopiclone is also metabolized by cytochrome P450 with a half-life of 6 hours. The duration of CNS actions of sedative hypnotic drugs ranges from a few hours, such as zaleplon, less than zolpidem equals triazolam equals esopiclone equals less than chloral hydrate. So basically the duration of action of chloral hydrate is the highest and zaleplon is the least. So more than 30 hours. So you have chlordiazepoxide, chlorazepate, diazepam and phenobarbital, long acting, right? Long acting barbiturate. So moving on to some high yield terms to learn. Addiction is the state of response to a drug whereby the drug taker feels compelled to use the drug and suffers anxiety when separated from it. So the person feels compelled to use the drug, so that is a state of response to the drug where there is compulsion to use the drug and anxiety when separated from it. Anesthesia is loss of consciousness associated with the absence of response to pain. Anxiolytics are drugs that reduce anxiety, or they're also sedatives. So lytic, lice, anxi for anxiety. So they lice anxiety, break down anxiety. Then dependence. So it is the state of response to a drug whereby removal of the drug evokes unpleasant, possibly life-threatening symptoms, often the opposite of the drug's effects. Hypnosis is the induction of sleep, and REM sleep is rapid eye movement sleep, and it is a phase of sleep associated with rapid eye movements. Most dreaming takes place during REM sleep. Then sedation is the reduction of anxiety. Hypnosis is the induction of sleep. You need to know these two differences. And then tolerance is the reduction in drug effect requiring an increase in dosage to maintain the same response, and that is tolerance. Okay. Moving on to the mechanisms of action of sedative hypnotics. No single mechanism of action for sedative hypnotics has been identified, and the different chemical subgroups may have different actions. Certain drugs facilitate neuronal membrane inhibition by actions at specific receptors. So the benzodiazepines, GABA is the transmitter most associated with inhibition in the CNS, and the GABA A receptor mediates this effect. Receptors for benzodiazepines or BZ receptors or BZ receptors are located on the GABA A receptor molecule and thus are present in many brain regions, including the thalamus, limbic structures and the cerebral cortex. So if this is, here you can see a GABA A receptor molecule, and the GABA A receptor molecule itself has BC receptors. Okay, so this entire thing is the GABA A receptor molecule, and it itself has molecules of BC receptors. Okay, barbiturate receptors, sorry, benzodiazepine receptors. Okay, so next, the GABA receptor chloride ion channel macromolecular complex is a pentameric structure assembled from 5 subunits. Penta stands for 5, each with 4 transmembrane domains. A major isoform of the GABA receptor consists of 2 alpha 1, 2 beta 2 and 1 gamma 2 subunits. Alpha 1, beta 2, beta 2 and 1 gamma 2. So alpha is 1, beta is 2, so 2 of each, and gamma 2. In this isoform, the binding site for benzodiazepines is between alpha 1 and the gamma 2 subunit. So benzodiazepines, as you can see, the BZ receptors in the GABA A molecule, they bind between the alpha and the gamma subunits. However, benzodiazepines also bind to other GABA receptor isoforms that contain alpha 2, alpha 3 and alpha 5 subunits. Binding of benzodiazepines facilitates the inhibitory actions of GABA, which are exerted through increased chloride ion conductance. GABA B receptors are coupled to potassium channels. Activation of these receptors, such as by baclofen, opens the channels and causes hyperpolarization. So benzodiazepines increase the frequency of GABA mediated chloride ion channel opening. So flumazenil reverses the CNS effects of benzodiazepines and is classified as an antagonist at the benzodiazepine receptor. So at the BZ receptors, there is an antagonist. What is that? Flumazenil. And then in contrast, beta carbolines, certain beta carbolines have a high affinity for BZ receptors and can elicit anxiogenic and convulsant effects. These drugs are classified as inverse agonists. Moving on to barbiturates. So barbiturates depress neuronal activity in the midbrain reticular formation, facilitating and prolonging the inhibitory effects of GABA and glycine. So barbiturates also bind to multiple isoforms of the GABA A receptor, but at different sites from those which benzodiazepines interact with. So their actions are not antagonized by flumazenil, and barbiturates increase the duration of GABA mediated chloride ion channel opening. They may also block the excitatory transmitter glutamic acid and at high concentration sodium channels. So here you can see a model of the GABA receptor chloride ion channel macromolecular complex. So it is a hetero oligomeric glycoprotein, and the complex consists of 5 or more membrane spanning subunits. So 2 alpha 1, 2 beta 2 and 1 gamma 2 subunit, and each has 4 domains. So receptors exhibit molecular heterogeneity. GABA appears to interact at two sites between alpha and beta subunits, triggering chloride channel opening with resulting membrane hyperpolarization. Binding of benzodiazepines and newer hypnotic drugs such as zolpidem occurs at a single site between the alpha and the gamma subunits. So, facilitating the process of chloride ion channel opening. The benzodiazepine antagonist flumazenil also binds at this site and can reverse the hypnotic effects of zolpidem. So, flumazenil, zolpidem, okay, Z for Z, okay, so they are antagonists and can reverse the hypnotic effects. Moving on to other drugs, so the hypnotic zolpidem, rapid-acting zaleplon, and esopiclone are not benzodiazepines, but appear to exert their CNS effects via interaction with certain benzodiazepine receptors classified as BZ1 or omega-1 subtypes. In contrast to benzodiazepines, these drugs bind more selectively, interacting only with GABA receptor isoforms that contain alpha-1 subunits. Their CNS depressant effects can be antagonized by flumazenil. Atypical drugs are discussed below, so the pharmacodynamics. The CNS effects of most sedative hypnotics depend on dose. They are dose dependent, as shown in this figure. These effects range from sedation and relief of anxiety or anxiolysis through hypnosis, facilitation or induction of sleep to anesthesia and coma. Depressant effects are additive when two or more drugs are given together. The steepness of the dose response curve varies among drug groups. Those with flatter curves such as benzodiazepines and the newer hypnotics are safer for clinical use. So those with the flatter curves are safer for clinical use. So you can see the relationships between dosages of benzodiazepines and barbiturates and their CNS effects. So the CNS effects are on the y-axis and the dosage is on the x-axis. So basically they start causing sedation and disinhibition and anxiolysis, then they lead to hypnosis, anesthesia, medullary depression and finally a coma. So barbiturates and benzodiazepines like this. The benzodiazepines, they kind of flatten out. And sedative actions with relief of anxiety occur with all drugs in this class. So anxiolysis is usually accompanied by some impairment of psychomotor functions, and behavioral disinhibition may also occur. In animals, most conventional sedative hypnotics release punishment suppressed behavior. Hypnosis. So sedative hypnotics can promote sleep onset and increase the duration of sleep state. Rapid eye movement or REM sleep duration is usually decreased at high doses. A rebound increase in REM sleep may occur on withdrawal from chronic drug use. Sleep patterns are less markedly altered by newer hypnotics such as zaleplon and zolpidem. So in anesthesia at high doses of most older sedative hypnotics, loss of consciousness may occur with amnesia and suppression of reflexes. Anterograde amnesia, which is the inability to recall events that occurred during the drug's action, anterograde, is more likely with benzodiazepines than with other sedative hypnotics. So anesthesia can be produced by most barbiturates such as thiopental and certain benzodiazepines such as midazolam. So moving on to anticonvulsant actions. So the suppression of seizure activity occurs with high doses of most of the barbiturates and some of the benzodiazepines, but this is usually at the cost of marked sedation. Selective anticonvulsant action, that is suppression of convulsions at doses that do not cause severe sedation, occurs with only a few of these drugs such as phenobarbital, clonazepam. High doses of intravenous diazepam, lorazepam or phenobarbital are used in status epilepticus. In this condition, heavy sedation is desirable. So, the relaxation of skeletal muscle occurs only with high doses of most sedative hypnotics. However, diazepam is effective at sedative dose levels for specific spasticity states, including cerebral palsy, and meprobamate also has some selectivity as a muscle relaxant. In medullary depression, so high doses of conventional sedative hypnotics, especially alcohols and barbiturates, can cause depression of medullary neurons, leading to respiratory arrest, hypotension and cardiovascular collapse. These effects are the cause of death and suicidal overdose. So 3 hours after ingestion of an unknown quantity of diazepam, a patient was hospitalized and the drug concentration was found to be 2 mg per liter. Assume that in this patient the pharmacokinetic parameters for diazepam are as follows. So the oral bioavailability is 100%. So apparent volume of distribution is 80 liters and clearance is 38 liters per day. Half-life is 2 days. So estimate the dose of diazepam ingested. So there's a formula, we'll discuss it later. Moving on to the tolerance and dependence. Tolerance is a decrease in responsiveness which occurs when sedative hypnotics are used chronically or in high dosage. Cross tolerance may occur among different chemical subgroups. Psychological dependence occurs frequently with most sedative hypnotics and is manifested by the compulsive use of these drugs to reduce anxiety. Physiologic dependence constitutes an altered state that leads to an abstinence syndrome or a withdrawal state when the drug is abruptly discontinued. Withdrawal signs, which may include anxiety, tremors, hyperreflexia, and seizures, occur more commonly with shorter acting drugs. The dependence liability of zolpidem, zaleplon, and esopiclone may be less than that of the benzodiazepines since withdrawal symptoms are minimal after their abrupt discontinuance. Moving on to the clinical uses. So, most of these uses can be predicted from the pharmacodynamic effects outlined previously. So, in anxiety states, benzodiazepines are favored in the drug treatment of acute anxiety states and for rapid control of panic attacks. So, benzodiazepines are used. Although it is difficult to demonstrate the superiority of one drug over another, alprazolam, medium acting drug, and clonazepam have greater efficacy than other benzodiazepines in the long-term treatment of panic and phobic disorders. Why are benzodiazepines used? Because the curve flattens out, okay, when you take CNS effects and dosage on y and x axis respectively. So they are safer, benzodiazepines. There is increasing use of a different drug group, the newer antidepressants in the treatment of chronic anxiety states. We'll discuss those later. And sleep disorders, so benzodiazepines including estrozolam, flurazepam and triazolam have been widely used in primary insomnia and for the management of certain other sleep disorders. Lower doses should be used in other patients who are often more sensitive to their CNS depressant effects. More recently, there has been increasing use of zolpidem, zaleplon and esopiclone in insomnia, since they have rapid onset with minimal effects on sleep patterns and cause less daytime cognitive impairment than benzodiazepines. Note that sedative hypnotic drugs are not recommended for breathing-related sleep disorders such as sleep apnea. Next, other uses. So, thiopentol is commonly used for the induction of anesthesia, and certain benzodiazepines, diazepam and midazolam are used as components of anesthesia protocols, including those used in day surgery. Special uses include the management of seizure disorders. So, clonazepam and phenobarbital especially are used in management of seizures. Bipolar disorder, clonazepam is used, and treatment of muscle spasticity, you use diazepam. Longer acting benzodiazepines such as chlordiazepoxide and diazepam are used in the management of withdrawal states in persons physiologically dependent on ethanol and other sedative hypnotics. So, diazepam you use it in muscle spasticity, phenobarbital you use it in treatment of seizures, clonazepam you use it in treatment of seizures as well as bipolar disorder. Next, toxicity. So, you have psychomotor dysfunction. This includes cognitive impairment, decreased psychomotor skills and unwanted daytime sedation. These effects are particularly dangerous when driving or operating other machinery. These adverse effects are more common with benzodiazepines that have active metabolites with long half-life such as diazepam or flurazepam, but can also occur after a single dose of a short-acting benzodiazepine such as triazolam. The dosage of a sedative hypnotic should be reduced in elderly patients who are more susceptible to drugs that cause psychomotor dysfunction. In such patients, excessive daytime sedation has been shown to increase the risk of falls and fractures. So, anterograde amnesia may also occur with benzodiazepines, especially when used at high dosage, an action that forms the basis for the criminal use in cases of date rape. So, anterograde amnesia may also occur with benzodiazepines, especially when used at high dosage, an action that forms the basis for the criminal use in date rape. So, zolpidem and the newer hypnotics cause modest day after psychomotor depression with few amnestic effects. However, all prescription drugs used as sleep aids may cause functional impairment, including sleep driving, defined as driving while not fully awake after ingestion of a sedative hypnotic product with no memory of the event. So, additive CNS depression. Additive depression occurs when sedative hypnotics are used with other drugs in the class, as well as with alcoholic beverages, antihistamines, antipsychotic drugs, opioid analgesics, and tricyclic antidepressants. This is the most common type of drug interaction involving sedative hypnotics. Overdosage. So, overdosage of sedative hypnotic drugs causes severe respiratory and cardiovascular depression. These potentially lethal effects are more likely to occur with alcohols, barbiturates, and carbamates than with benzodiazepines or the newer hypnotics such as zolpidem. So, management of intoxication requires maintenance of a patent airway and ventilatory support. The flumazenil may reverse CNS depressant effects of benzodiazepines, ezopiclone, zolpidem, and zaleplon, but has no beneficial actions in overdosage with other sedative hypnotics. Moving on to other adverse effects. So, barbiturates and carbamates, but not benzodiazepines, ezopiclone, zolpidem, or zaleplon, induce the formation of the liver microsomal enzymes that metabolize drugs. This enzyme induction may lead to multiple drug interactions. Barbiturates may also precipitate acute intermittent porphyria or AIP in susceptible patients. Chloral hydrate may displace coumarins from plasma protein binding sites and increase anticoagulant effects. Moving on to atypical sedative hypnotics, you have buciprone, which is an anxiolytic. So, buciprone is a selective anxiolytic with minimal CNS depressant effects. It does not affect driving skills and has no anticonvulsant or muscle relaxant properties. It interacts with the serotonin receptors of 5-HT1A subclass of brain serotonin receptors as a partial agonist, but the precise mechanism of its anxiolytic effect is unknown. Buciprone has a slow onset of action greater than 1 week, and it is used in generalized anxiety disorders but is less effective in panic disorders. Tolerance development is minimal with chronic use, and there is little rebound anxiety or withdrawal symptoms on discontinuance. Buciprone is metabolized by CYP3A4 and its plasma levels are markedly increased by drugs such as erythromycin and ketoconazole. Side effects of buciprone include tachycardia, paresthesias, pupillary reconstriction, and gastrointestinal distress. Buciprone has minimal abuse liability and is not a schedule controlled drug. The drug appears to be safe in pregnancy. So, moving on to melatonin receptor antagonists, so ramelteon and tasimelteon activate melatonin receptors in the suprachiasmatic nuclei of the CNS and decrease the latency of sleep onset with minimal rebound insomnia or withdrawal symptoms. These agents have no direct effects on GABAergic neurotransmission in the CNS. Unlike conventional hypnotics, ramelteon appears to have minimal abuse liability and is not a controlled substance. The drug is metabolized by hepatic enzyme cytochrome P450, forming an active metabolite. The P450 inducer rifampin markedly reduces plasma levels of ramelteon and its metabolite. Conversely, inhibitors of CYP1A2 such as fluvoxamine or CYP2C9 fluconazole increase plasma levels of ramelteon. The adverse effects of the drug include dizziness, fatigue, and endocrine changes including decreased testosterone and increased prolactin. Tasimelteon is approved for the treatment of non-24-hour sleep-wake disorder. Tasimelteon, so non-24-hour sleep-wake disorder. So, orexin antagonist. Orexin is a peptide found in the hypothalamus and is involved in wakefulness. So, suvorexant, an antagonist at OX1R and OX2R orexin receptors, has hypnotic properties and is approved for the treatment of insomnia. So, that is all about this chapter. So, moving on to the skill keeper answer. Dose ingested is plasma concentration into the distribution volume. So, that is 160 mg in this case. Half-life is 2 days, so one may assume that the plasma concentration 3 hours after drug ingestion is similar to the peak plasma level. So, assuming 100% bioavailability, this is the dose ingested. Okay, and that is the answer to the question. This is the basic summary of what we have discussed so far.